now we are afternoon. My talk will be a case report, which is titled as Unexpected Epiglottic Cyst in Traumatic Patient with Difficult Intubation. So our patient is a 52-year-old male, referred as life-saving RTA victim, intubated with the endotracheal tube size 6, which is small size, on mechanical ventilator and sedation, and he was referred from peripheral hospital. The patient has neither medical or surgical illnesses. On examination, patient was stable vitally. The GCS was 4/15. The pupils was sluggish. He had left neck surgical emphysema, left clavicular and scapular fractures, diminished air entry on the left side of the chest. Abdomen was extended with some bruises, but there is no obvious facial or neck injuries or swelling. Patient had been admitted in the ICU. On the first day of admission in the ICU, the team was planning to change the endotracheal tube by a larger tube. So the smaller tube was removed, then the larger tube, which is 7.5, has been tried to be inserted, but was stuck and failed. So the patient developed hypoxia, reached up to 50 over 25 minutes. At that time, the glycoscope showed quite big lesion occupying whole area of the hypopharynx. So an expert intensivist was called, and he succeeded to insert it. So this is the lesion, which is a big occupying the hypopharynx. This is the endotracheal tube. The lesion was in front of the endotracheal tube. One day after this event, the CT neck with contrast was done and showed well-defined cystic lesion in the hypopharynx. So 5 days after that, the patient was booked for tracheostomy and surgical cyst removal. Intraoperatively, the cyst was excised, which was originated from the left side of the epiglottis. And the lesion was sent to the histopathology that showed a thickened wall cystic structure measuring 1.3 centimeter in diameter, ductal versus circular cyst. The postoperatively was eventful, and the patient was discharged after 2 weeks to the IMCU, then to home when he was improved totally. On the clinic, 1 week after, the endoscopy was done for the patient, and the wound was found to have healed completely with no recurrence. So regarding to the discussion of the case, as we know, the epiglottic cyst is a rare benign lesion which commonly arises from the lingual surface of the epiglottic region. It's known as an epiglottic mucosal retention or base of the tongue cyst. There are several hypotheses that explaining the epiglottic cyst, but the two major hypotheses are ductal obstruction or embryological malformation. For the management of epiglottic cyst, the conventional modalities like marsupialization or bioexcision, which achieved by the carbon dioxide laser, electrocautery, or snaring of the cyst. Regarding to the management of the airway, it's either by the intubation or ventilation by the mask. If failed, we will go furthermore for the cannot intubate, cannot ventilate situation. This is the algorithm of management of anticipated difficult tracheal intubation in adults, which was published by the Airway Society in 2015. We have a plan A, B, C, and D. We are starting by the ventilation and intubation. If failed, we will go for the supraglottic airway modalities or devices. If failed, we will go for the face mask ventilation by two-person technique. The last, if all these failed, we will go for the surgical airway modality. So non-surgical solution for the cannot intubate, cannot ventilate situation, including the laryngeal mask airway, esophageal tracheal comi tube, or transtracheal jet ventilation. The supraglottic ventilatory options may fail because they are providing the supraglottic ventilatory mechanism, or they are traumatizing the cyst, so it will result in bleeding and aspiration. So the solution now, the ventilatory mechanism below the lesion by either transtracheal jet inflation or by surgical airway. When I did literature review, all the cases was unexpected during the anesthesia. My case, only the one was caused by the trauma and incidentally discovered after trauma. So all these cases were treated by needle aspiration inside the operative room. So our conclusion in preparing a patient with a small-sized ATT for endotracheal tube changing or history of airway difficulty, the meticulous airway assessment and proper planning are mandatory as any difficult airway scenarios. Tracheostomy should be planned in advance if the epiglottic cyst obstruct. Thank you so much.